This presentation was recorded at the 2015 ANZICS ACCCN Annual Scientific Meeting.
Our first presenter is Dr. Carl Horsley, an intensive care specialist at Middlemore Hospital here in Auckland. You can probably read Carl's bio, but there's one key bit of information that he's left off that, and that is that Carl is a deep and reflective thinker. And I have no doubt that it's because of these attributes that this has led Carl to spend a lot of time thinking and pondering on how we can do things better, not just for our patients and their families, but also for us in the intensive care. Carl's going to be talking to us about resilience and what that means in medicine, and also how we go about addressing safety in the critical care, which is obviously an incredibly complex arena. So, Carl, please.
Good afternoon. So apparently I mumble and talk fast when I get stressed, so I'm relying on you to sort of either kick me or wave at me. Thank you very much for coming along today. The title of the talk is Turning Safety on its Head, and then talking about team resilience for the everyday. So for those of you who are here expecting that it's about your own personal resilience, I'm afraid it's not. It's about, I'll come to what it actually is. For those of you who are here to see whether ketamine can help with resilience, it won't. And so actually what we're really talking about for me is this is an engineering view of resilience, which is the ability of the team and the system to monitor and adjust its performance both before, during and after challenges or disruption to the system, that it can still achieve its goals even when the unexpected things are happening. So I'm going to talk about patient safety, but first of all, I'm amongst friends here because I know you all work in ICU, and it's a really stressful place. It's a place where there's lots of stuff goes on, and we've heard about burnout rates and that are very high, and the stress that goes with all the work we do. I want you all to cast your mind back to a case that you were involved in where you felt that things didn't go quite as planned. Either there was something you did or something you didn't do or something you missed, and there was a bad outcome for it. I don't want you to tell me about it. Most of us can remember the names of these patients 10 years later, and they're cases that are very personal to us. But I want you to cast back to think about it, how it felt when you first found out, how it made you feel about yourself, and then what you promised you would do, or how would you respond to it. And I've asked this question to quite a lot of the staff and people I work with, and the common things are surprise or shock. The second thing is this feeling of, there's something dreadful, this awful thing. And the challenge that it has to ourselves, and it really challenges how we feel about our role as doctors, nurses, other people in the healthcare team, and the system as a whole. It really challenges the whole way we feel about it. And the usual response is we promise we'll never make that mistake again. And we usually don't, but we usually go on to make other mistakes as well. So patient safety has been talked a lot about, but actually it's not just a patient safety issue, it's a staff safety issue as well. So I'm going to talk a little bit about the current model of safety. I'm going to talk about some of the problems with the current model. I'm then going to go and talk a little about the new view of safety. We talk a lot about safety models coming from aviation, other places like that, but we're pretty much 20 or 30 years behind where aviation's at. So I'm going to talk about what's actually going on in the real safety science that's going on now in a different model, and then talking about how we've implemented it at Middlemore, or tried to. The plan is I'll talk for about 20 minutes at the start. We'll have a bit of a break for a couple of questions, and then we'll go on and we'll do that last section about how we've implemented it and leave some time for questions at the end. So just a bit of history. Most of you will be aware in 2000, the Institute of Medicine released a book called To Err is Human. I'd like to draw your attention first of all to the title. It's all your fault. And it said basically there were sort of 50 to 100,000 people killed in the American health system every year as a consequence of their healthcare being delivered. And there was a huge outcry. There was just a massive outcry about this. And Bill Clinton promised that he would do everything they could to reduce the harm from healthcare. They were going to halve it in 5 years, and they would do whatever it took. So from that first thing, the definition of safety, and quite a common view of safety, is that we want to do things as well as possible. As few things as possible go wrong. So we started with 100,000. We want to get that down by half. As few things as possible go wrong. So the current model really is that there is, if everything's going well, everything goes well. There's a good outcome. So the process works, the outcome's good. At some point, at various levels, there's a transition. Either it can be a sudden thing or a gradual thing, and things change, and we have a malfunctioning or some problem in the system. And we end up with something that shouldn't be happening, and a bad outcome. And the reverse of this, obviously, is there's a bad outcome. We need to go upstream and look for what caused it. Does that sort of feel familiar? Yeah. This is developed into various safety models, including the Swiss cheese model, which is by James Reason, where he said basically these faults, these problems in the system can exist at many levels. They can be from the managerial level, the policy level, the individual things that we do or don't do, and the failure of defences that we put in place to ensure that harm doesn't happen. So the model has therefore led to us to find and fix these holes, find the problems, try and find out where they are, and patch them up so they never cause that problem again. We talk a lot about compliance. The model, remember, is if everyone does the right thing, nothing bad should happen. So we have the 5 rights, the 5 moments, checklists, we have guidelines, protocols. Most hospitals have about 1,000 protocols. And we're very focused on compliance. And your hospital wants you not to stuff up. Please do not be uncompliant. Do not make any mistakes. And we see this with the way that the work we have is described and the policies and procedures is used to then beat us around the head when something goes right. Well, you didn't really do what you should. I'd like you to go back and learn the 5 rights. Please go and learn them. Clearly you don't know them. The other thing is we put in more defences, more slice of cheese. We put in more and more obstacles. We're going to do a scoring system. We're going to do another section of the admission form that says, you need to screen for this problem. You need to think about this problem. We make work more and more and more complicated. We put more and more defences in there. And within this model, people are a liability. This was actually quite amusingly opposite our safety work, which is hilarious. But it says that the number one hazard is you. And that's kind of the message that we receive. And this sometimes gets sort of distilled into this idea, if I could just get rid of the bad nurses or doctors, then the system would be fine. We've just got to try and find out who they are and get rid of them and we'll be okay. And when errors happen, when things go wrong, it really challenges our sense of ourselves and the system, as I said. And this is a recent article that many of you will have seen about an emergency doctor who sent home a colleague's child who came back with meningococcal disease. And that's, again, that sense of surprise and the dreadful feeling it had. And what did I miss? Because he's starting with the end, the effect, the meningococcemia, thinking, what did I do wrong? I must have done something wrong. There's something there. And more close to home, we have a recent case here where a nurse gave a 10 times overdose of metoprolol. She was prescribed at 11.875 milligrams, and she gave 118.75 milligrams, which is actually a normal dose range. And the patient died. And again, I want you to note the surprise here: a previously unblemished record. This was in the recent. This is actually in the papers. This is not a report on something that's closed. This is in the papers. So this view of people as a problem has therefore led us to think about, well, how do we automate stuff? How do we get rid of people out of the system? How do we remove as much as possible the human error, the things that people are doing wrong? And you'll see this with the electronic dispensing, with some of the other things. We're really trying to take people out of it. We have robots to dispense stuff and do things, and we're really trying to get people out as much as possible. So the summary then is that the definition is as few things as possible go wrong. It's always a reactive system. We're always going, well, there was a problem, so now we need to look at it. And it only responds when something happens, or when we reach a threshold where that was a near miss. The view is that humans are predominantly seen as a liability or a hazard, and accidents are to find the failures and malfunctions and to identify the causes and to fix them. So how's that going? 2010, this is a Landrigan study, quite a prominent study actually, and they looked at a whole 10 hospitals in North Carolina and found there was basically no change in the error rate. There have been other studies again looking at the changes in error rate, and we're really not seeing it. It's particularly look at the overall adverse event rates. And the nurse that we fixed and found, well, actually, turns out this wasn't in the press. This was actually in the Health Quality and Safety Report. And it says that actually it wasn't this person. There were 3 events and another death as well. So there's something going on that's not to do with that person, not to do with the person standing nearest the problem. So let's talk about why this isn't working. Oh, sorry, just coming back to checklists. Checklists, again, we've seen from the original data that came out saying it was a great effect. We're now seeing that it's having a variable impact into clinical practice. It's not working quite the way we thought it would. So, The system is reactive. It only responds when something's gone wrong. It always starts looking backwards. And as soon as you start looking backwards, things change. We talk about hindsight being 20/20, but it's really not. It's kind of like being on ketamine. It's, you see things that aren't really there. We look back and we make sense of the story. We're kind of sense-making creatures. That's what we do. And we don't actually see the truth when we look back. We see the bits that make sense to explain how we've ended up where we are. And it immediately brings in a big bias to that. So we start with effect, and we look back, and we're looking for cause. But real work is not like that. Real work is actually complex. There are things going on. This is an emergency department, by the way. And just so you know, the emergency and intensive care are recognised as having the highest complexity. And funnily enough, is having the highest rates of burnout. It's really weird. So healthcare is not actually linear. It's not cause and effect. There are things that are changing all the time. It's actually a very complex system. And the decisions we make are not based on something where we can see the outcome. We choose not to go that way. It's, if you like, this is a braided river down the South Island where we're constantly making small decisions that we don't know the outcome, but they seem like the best decision at the time. And sometimes they lead us to unexpected places. So whenever we think about things, we actually have to think about how did that seem the right thing when we were going forward making those decisions rather than when we knew the outcome looking back. The other thing that's created is this real tension between safety and the clinical work we do. Safety is something that's done to us. It's somewhere out there. And you know this, you send an incident form off and they'll get back to you with the solution, they'll let you know. It's something that we do when we've got time. We know we should, but it's sort of, there's this kind of tension between, yeah, we know we should, but we've got to get people in and out and get the beds doing, and the surgeons want to cancel cases if we don't do this. You know, there's all these things. So we set this tension between doing it safely and doing actually what we need to do every day. And unlike in most places, we can't press a pause button. We can't stop and say we're not going to go ahead until it's safe. We have to keep going because there's risks with not doing stuff as well. It's really limited our learning about the system. We know an awful lot. You think about the resources brought to bear on when a case goes badly, and we bring a huge amount of resource to bear on a case that goes poorly, this little red bit down the bottom. But we have no idea why it normally works. We don't really, and if it goes exceptionally well, that's awesome. You guys are fantastic. Whew. But actually, a lot of our work is very difficult, and we still manage to make it go okay, but we don't really understand why. Because these are rare events, it means that we're often putting in place systems that are we're responding to something that is very rare and very unlikely to happen again. And the problem we have next time won't necessarily be the problem we have previously. And when we bring everything to reduce variability, to get rid of that sort of adaptable response, we can actually make the system more brittle because we're now not dealing with a new problem. It also hides the sources of resilience, the ability to change what we're doing. And you know what I mean, like there's a protocol that says this is how you do it, but there's always the phone call you make to make it happen. The person you contact, you know how to do it. The workarounds that we do to make sure that things happen. And we kind of hide that away. And it also reduces the innovation because we're saying this is the right way. We have been to the centre of excellence, we have found the right way, and we will now all do it that way. The other thing is the cheese is alive. We kind of look at the system like it's a factory, like it's really, really safe or not safe. It's a property of the system. But it's not. It's more like this. The system is constantly changing. Safety is not safe or not safe. It changes depending on our workload, the patients we have, the staffing, the skill mix, the alignment of planets. It feels quite random sometimes. And we actually don't exist in a factory with a production system. We exist actually in a complex, adaptive system where things are constantly changing. And we are interacting with each other, with other teams and our team, and with the machinery and technology we have around us and families. And to deal with that, we are constantly making trade-offs. Okay? And this is the concept, ETTO, the efficiency thoroughness trade-off. We want to be safe. Safety is number one. Yay. And there's a 6-hour target or 4-hour target in ED. Okay, cool. And this is actually a thing that we apply all the time. Like, the efficiency of me, I have to actually have the talk to be able to do today versus the thoroughness of what I want to say about it. So, and it's the same with investigations. It's the same with the clinical decisions we make. If we are really, really, really thorough, the system stops. So we are constantly making trade-offs, and we have to judge that. We have to make those judgments as to where that thing lies. And that's really tricky. And I'll talk more about that. So this is the new view of safety. This is from a guy called Eric Holnagel. So for those of you who've read a bit of safety, James Reason is sort of the guy for safety. He's the person who's done the Swiss cheese model, a lot of thinking about it. And Eric Holnagel is kind of the next person I think we'll be thinking about in those terms. There's a recent British Journal of Anaesthesia article that's just come out talking about some of these concepts. This is starting to hit the horizon now. And this is based on the guys who are safety scientists. And what they're saying is actually there's not good things and bad things. They're saying when there's been an incident or an event, usually the behaviours that led to it have actually been done many, many times before and have usually worked. And you guys know this. We talk about workarounds like they're a sort of an evil bad thing, but they're often how we make the system work. And we're going to work to rule. Okay, the system will now stop. We know there's things we do that make the system keep going. And usually they work, and sometimes they don't. And it's not their inherently good or bad decisions. It's just the conditions around them change. So in this one it says that actually we're constantly adjusting our performance and that it can lead to either good outcomes or bad outcomes depending on the conditions. So there's no right answer anymore. There's only the best answer given the situation you find yourself in. And to me that feels like real work. That's someone telling us what we do every day. So the aim of this new model, and we call it Safety 2 just so when you see the stuff in the literature you can start to recognise it, is that rather than focusing on how do we make sure nothing bad happens, we say, how do we make it more likely that the good things will happen? So it's a complete shift. And by the way, less bad things will happen because you're doing more of the right stuff. But it's just our focus, trying to understand, well, why does it normally work and what were the conditions that were different here? So we come back to the resilience that we want. So resilience is the ability of the team and the system to monitor and adjust its performance before, during and after to achieve its goals, even when the unexpected happens. And so the idea here is about trying to understand how do we increase the range of conditions in which we can successfully deliver a good outcome. Now, this is actually before the Safety 2 stuff sort of came around, but this is really interesting when we look at it through this lens. This is a study of about 19,000 surgical patients looking at really awesome places and really not quite so awesome places with surgical outcomes. And what they found was the complication rate up on the left there wasn't that different between the high-performing and the low-performing hospitals. What was different was that they were able to see the complications, to respond to them and to prevent them causing death or other complications. So it wasn't we've got rid of error and we've got rid of harm and stuff. It was actually we're recognising it was happening and we're responding appropriately to it to prevent it causing death. The other thing that's really interesting about this is that the system only succeeds because people and teams are able to adjust to meet the conditions of work. Sometimes they don't. But overwhelmingly we adjust to meet the conditions of work, which is why it's almost like a miracle that everyone gets out of ICU. You know, it's not like, oh, that was good. It's something we work really hard at. And this is a message I haven't heard for a while. People are the solution. Because people are the best way that you can deal with complex environments and difficult decisions, because we weigh stuff. If you write an algorithm for a computer, that's fine, but it operates within its limitations. Whereas people are very adaptable. It's what we do. So, the new definition of safety is we're going from a passive reactive state where safety is when nothing happens to a state where something where safety is something we create every day. The idea is proactive. It's continually trying to anticipate developments and to mitigate harm and things. And that humans are seen as a resource you need for this flexible adaptive system. And the purpose of excellence now, suddenly, instead of being about like, you know, what didn't you do right, and things, trying to understand what were the conditions you found yourself in and why what you normally do didn't work this time. So there's some principles. Rather than just focusing on what went wrong, do we understand what went right? So let's start looking at what went right. Understanding what were the workarounds, what were the hard things that made that recess go well. Yeah, we go, yep, good outcome, nothing to learn, walk away. But if we actually stop and say, was there anything unexpected that happened there? We often find that the team has had to adjust and do a whole lot of stuff to make it actually have the outcome that we got in the end. But we haven't, at the moment, that's all hidden away. Focus on the regular. A 1% change, a 1% improvement in our overall performance, and we heard it this morning with the Bristol Kids stuff, that small changes in our team performance are likely to have a bigger impact than a big change in a very rare event. Okay, so thinking about what's regular. Anticipating how things might fail. Okay, the natural state of the system is not that if everyone does their job, it'll all end up being okay. We have to work hard to make it be okay. So the idea is we are anticipating, we know what to expect. How should it go? What would it look like if it's succeeding? And what might happen? The difference between this and threat and error management, where we just say what are the bad things on the horizon, is that we're actually describing what we expect to happen. And then if we get something unexpected, it's something that's different to what we were expecting, so we can start dealing with that. We want to know what to look for, what to monitor. We want to be able to respond. We want to know what to do. And we used to have this great thing, which was, if the airway, don't let the airway fall out. We do max fax cases. Don't let the airway fall out. Very bad. We're now talking about saying, okay, if the airway fell out, what would be our plan about that? And we originally, one of my colleagues was saying, don't tell them, it'll just scare them. And what we're finding now is actually that people are they feel a bit more mellow because they're like, okay, we've got a plan for the first 5 minutes, and actually it'll be okay. And the really big thing is trying to reflect on your practice, trying to know what has happened, trying to learn from it. A really key one here is understanding that success and failure come from the same source. Okay, they are not good behaviours and bad behaviours. The same things, the variability, the innovation, the ability to work around stuff is the flip side of the things when we don't follow protocols and we go off and it doesn't work out. Okay. So the reason this is important is because sometimes the defences that we put in, the slices of cheese that we add, mean that in actual fact we are making it harder to do the work we do every day. And you guys have seen that. We've got these things now with the electronic prescribing where you can only get the medications at a certain time because that's the safe thing to do. So type it in, and it means we can't adapt, we can't adjust to work out what's best for the patient. When they're sleeping, how do we get our cares done, all those sort of things. So people find workarounds, and sometimes we actually make it less safe because people are having to find workarounds around these big things we've put in place to make it safe. So, to err is human, but so is to be adaptable and innovative, and we create safety every day. For those who want more information about this model, this is there's a recently released white paper on Safety 1 to Safety 2 as applies to healthcare and a website. And for those of you feeling particularly ambitious, there is now an international prize for a project involving resilient healthcare principles. It's $5,000 US, which goes up every day, I think, if you're in New Zealand. I would encourage you to look at their site and have a think about how some of these things affect. This is not truth. This is just I'm letting you know where safety is going. Right. That's the end of the first part. Should we have a couple of questions? Should we keep going?
Well,
Any
the
questions?
gizmo doesn't seem to be working particularly well, as there are no questions come through so far. Carl, are you saying that, so safety 1 is that an error occurs or an event occurs and we look back and address it. Are you saying we shouldn't be doing that then? We should... That kind of model's gone, or surely there's still things to be learned from that.
So the thing you see there is not learn only from when things are going well. The thing is learn from all events. So it's not safety 1 and safety 2.0. It's a new version. Safety 2 means learning from all events, including those where things didn't go well. And so I think there's no safety 3, okay? Because safety 2 is basically we're going to learn from when it doesn't go well, when it goes exceptionally well, and the bit in the middle. So you can't have a system that's more than that. So no, we still need to look at events. No, we still need to be thinking about some of those things. But probably our approach needs to change. If you accept that the things that normally work are the same things that sometimes don't in different conditions, you do approach looking at stuff differently. And there's a great quote which is that this is from James Reason, the safety guy, and he said the root cause is whatever you happen to be working on when the time or money runs out. So we create cause. It's a construct of where we choose to stop and assign that proportion, that blame, or that causality. But we could go back further. We could go back to the teaching and the selection and the support and why didn't someone speak up and how the systems put in place that anticipate that someone might do something wrong. So I think it is about learning from all those events, but it is a change in that lens.
So lovely talk, and I'm like 98% sure you're right. But I'm also an intensivist.
Yeah.
And so for the last 50 years, I've heard lovely talks that started from first principles and discussed compelling logic.
Yeah.
And then when we finally got around to trialing them, usually by the CTG, proved to be at best no better and actually harmless. Can you talk a little bit about how we would know if this was right?
I can tell you about our experience. One of the difficulties, and this is, as I say, this is all incredibly new, and this is one of the difficult things is you're trying to measure the potential capacity of a system to respond to change. So you're not measuring a static property of a system that you can measure. You're measuring its ability to, if you hit it, does it wobble and come back? Okay. So it is very, very tricky. And I think the things I would be looking for, and this is, like I say, this is something that people are working on. They've developed some tools like resilience analysis grid about what is our capacity to be able to anticipate, monitor, learn, all those sort of things. But I think that is the bit that's the trickiest. I can only describe the behaviours that we see where we're working, and I think it would be really good to actually look at it, because a lot of what we're measuring nowadays are things like safety attitudes questionnaire, which are things that people tell you, but not necessarily what people do. And I think it is very difficult to measure these things, but I'd be very keen to engage with people who have more thoughts about measurement. I think it's really tricky. So I carry on and show you what we're doing, and I'm hoping for a volunteer at the end of this to say we'd like to try to as well and measure some stuff. How's that sound? I hear a volunteer in the second row. That's great. So this is, I work at Middlemore. For those of you who don't know, Middlemore is a medium-sized intensive care unit. We take children down to about 2.5 kilos. We are the National Burn Service. We do mainly adults, so up to 350 kilos. There's Middlemore big, and then there's big. You know, people go, it's 120 kilos. We go, yeah. And we also now do a super regional spinal service for the North Island. So we do a lot of stuff, and we have a lot of people from different cultures. We have a lot of different staff coming in, and now we have a lot of poverty, deprivation, lots of pus. It's a great place to work. And fantastic people there. We are also part of Middlemore Hospital, which is part of Coatea, which was for a while until I had to pay the bills, strongly aligned to the IHI. We have done every intensification of safety thing you could do, every expedition, every zero patient harm. We won the lead places for CLAD Zero. We even have mindfulness for personal resilience. We've done it all. And yet we were still not seeing the safety behaviours and changes that we really wanted to see. And we had aligned our nursing and medical education days. We had an in-situ program where we would regularly do in-situ simulations using our real equipment. Our staff had those regularly and were performing quite well. But we weren't seeing the changes on the floor, the day-to-day. We were seeing better crisis stuff, but not the changes that we really wanted on the floor. And so we thought about a different way. And the reason I can't... The good thing with measurement is you have a state at the start, and then you change something, and then you measure at the end. And I have to say that our one has been a 4-year journey of starting from simulation somewhere else to bring it in-house, to allowing the medical nursing days, to having a framework that's we've developed, to now sort of, you know, looking at it through this lens. So the change has been organic, and it's been very hard to measure that. But the aim we were looking for now is to look at the Safety 2 stuff and think, how do we build our capacity for resilience in teams and systems? And how do we make it easier that we go to the right thing? How do we make it easier to do the right thing? Now, we talk a lot about teams, and I know everyone's going, oh yes, teams, we talk about teams all the time, but when I say teams, I mean teams between nursing and medical and allied health and patients and families and other services. It's all the same stuff, okay? And the difficulty has been that often when we've tried to build teams through simulation programs and things like that, we keep talking about crisis. It's always a disaster. It's always the crisis stuff. We don't see the teamwork that we do every day, and we don't make the connections from that crisis teamwork to actually how it works every day. So we developed a framework that we thought, well, actually we need to be able to describe what good teamwork looks like. Not just in a crisis, not just around the bed space, but actually overall. To start with, one of the most difficult things, which is a shared understanding of the situation. And we use standard tools, don't get me wrong, but we start with this. This is sometimes what people leave till the end. They talk about, you know, communication and roles and stuff. But actually, if you don't know what the situation is, how do you possibly know what roles and priorities there are? So we took SBAR, pre-brief, recap. But more importantly, this is the same stuff that we're seeing built into the way we now run the unit. And if you think about it through this, the handover is the way that you get the idea of what's going on. The ward round is actually a pre-briefing. It's saying these are the priorities for the day. This is what we're trying to achieve. And then we're going to do the reviews, which are a recap of making sure that everyone's on the same page about this. And there's been plenty of studies saying that actually the shared understanding of what the situation is does not often occur in ICU, or not in the way we would hope it would, and Brian Cuthbertson's done some lovely work on that. We talk about role clarity, but one of the big changes we've made is moving to this idea that if people need to be adaptive and you have all these complex problems, you actually need multiple lenses to be able to look at it. So leadership then goes away from this idea of we need strong leadership that tells people what to do, So leadership is about setting the priorities and creating a climate where everyone can contribute to it. And that does include the patient. And if you take this to the logical extreme, actually this model means that a patient could be the team leader because it says this is what's important to me and this is what I want from you guys. We still do the clear communication stuff. You can't get around the transmission problems. But we spend a lot of time teaching readbacks and all that stuff, but it's a small thing compared to our daily understanding of what is the situation we find ourselves in. We talk about speaking up. Our model we use is actually inquire, advocate, assert. Hey, are you seeing what I'm seeing? Yeah, I think we should do something differently. Okay, this is not going to plan. I'm call for help. That's just how you build the team. That's kind of like the ticket to ride, the entry point. But what we're really now focusing on is anticipating how things might fail. So on a ward round, we'd say, by tomorrow morning, I would expect that we'll be about here, we'll be weaning this down, we'll be doing all these things. So everyone now has a clear picture of what is the trajectory that we're aiming for in the next wee while. How should it go? We will also outline the fact that, well, this is what I'm really worried about, this is what it would look like, it's day 3, they've got some tummy pain, we're going to be looking for fever, we're going to be looking for all those things. But being able to actually say, this is what I expect to happen, is a really big step that we often don't do. And when we do this in our scenarios now, we're talking about actually people saying, this is what we're going to do, this is what we expect to happen, and this is what we're worried about. So we spend a lot more time pre-briefing and talking about things that might happen and letting people get a sense of what's going on. We build in time for reflection. This is something, I don't know about your unit, but we're often so busy we don't actually ever stop to think why it worked. And because it's such a limited resource, this ability to sit down and reflect, we often only do it when things have gone wrong. But actually, just setting aside a bit of time after a recess or after whatever, a ward round, or just to catch up in the afternoon. So if you're debriefing a recess that went well, say, hey guys, how'd that go? What worked? Why did it work? What were the problems we had? What do we have to work around from? And in the same way, building that time if you're on a ward is saying, okay, this is where we thought that the unit would go, in the unit. This is how we thought the admissions and the discharge would go. Where are we at? What's our staffing like? How are things working? What do we need to do? So you're constantly updating your model, setting aside time to learn from what's going on. And we learn from all events. So you can't do it for everything, but particularly with like intubations, resuscitations, peak trachea, any procedural stuff or things that are unexpected, you can actually go back and say, look, what happened the way we thought it would? What were the surprises? What did we miss? And what do we have to do improvise? What were the workarounds we did? What were the things we had to look for? And this is from the work by Todd Conklin, who's the Director of Safety at Los Alamos. They're an explosives research place, which sounds awesome. But that's setting aside time to understand why things work is something we don't really do very much. And when you have incidents, the focus is not on trying to work out what was the cause. The focus is trying to understand why did that seem the right thing at the time. Someone does something that's immediately crazy and you just think, help me understand why that seemed the right thing at the time. Because what you'll find is that person is in a situation that other people could be in, and actually you'll find that that's a replicatable problem. And we saw that with the metoprolol case where it was a 11.875, a very unusual dose, but other people were placed in that same situation. The other thing is when you're thinking about what interventions you're going to do, think about, will my intervention to make things safer make it easier to do the right thing or harder to do the wrong thing? And our focus now has shifted to trying to make it easier to do the right thing. So we have a really interesting thing. We have is everyone doing CLAB? Central line and things? So a lot of the reason it's put forward is because we have a checklist now and it encourages nursing and doctors to talk to each other and they note each other what's going on. We have this thing where we're actually quite busy, so sometimes the nursing staff don't watch the doctors and they come back and they go, tick afterwards. I'm sure it doesn't happen anywhere else. We're very compliant with the checklist. But we've still had a massive decrease in our CLAB rate, and it probably turns out that what we've done is that we've made it easier to do the right thing. It is now easier to grab a CLAB pack where everything you need is in there than it is to wander around going, where's the hat, where's the mask, where's the, oh, bugger. So we've actually made it much easier. The next one here is, I'm not saying don't wash your hands, by the way, but this is the 5 moments of hand hygiene. And most medical wards or surgical wards, when you go there, they have really good compliance rate because they watch them go into the beds and they go, yep, tick. They don't actually, off the corridor into the room. They don't watch them beyond that. For ICU, everything is out there for you to see. And the estimates for hand hygiene for ICU are that there are about somewhere between 100 and 200 moments for hand hygiene in a 12-hour nursing shift. And the recommendation from HQNS, I think, is 20 to 30 seconds, including with alcohol gels. So it's about 90 minutes of hand washing in your 12-hour shift with a critically unwell patient. So it's not surprising that we don't do it all the time. So actually what we're doing is we're now working with our infection control people saying, rather than just tell us we're not doing it right and to try harder, come and help us, come and explain to us what's really important. How does this fit with our workflows? What do we do? How do we make it easier so that people can do the things that are going to make a difference rather than just punishing them for not doing the right thing? So what are we seeing? We're seeing teams that are a lot better at briefing and responding stuff, and we have a kind of phrase which is a critical non-event. Something bad happened and there was no problem because we were kind of ready for it. And we are getting much better at adapting. And the way it works is in a simulation, we'll run one simulation which is about the team, how do you develop a team, and the second one is something unexpected happens. And I see some of the registrars here, so they're now onto it. The second scenario, something quite unexpected happens, and it's about how do you create a juggernaut where people are expecting one thing to happen, and how do you then rapidly change and move on. There's no right answer. It's just about how do you adapt, and how do you practice that. And the links back to the everyday about how do we respond when things aren't going to plan. So that was, yeah, we were kind of happy with that. We got some real surprises though. What we found was that at the start of this I was a bit scared of the SMO group because I'm very shy and retiring. But we initially did the registrars and the nursing staff, and we taught them about this, and we talked about this framework about how does leadership look. And after a while the SMOs started coming and saying, we're getting some strange questions like, so who's leading this? What's the plan? What are you worried about? What should we get ready? Can we talk about a plan for failure? And what we realised was that actually in the past we built this, a lot of the sim programs, a lot of the stuff we do is built around strong leadership. We need good leadership. But actually what we found was that followers, active followers, who are anticipating stuff going a certain way, can actually ask for the behaviours that they need. So we've created a system that doesn't fall down when there's a lack of leadership, because the followers actually ask what they need for. Wasn't thinking that would happen. Another big surprise is we don't talk about speaking up very much anymore. We used to always be like, if you see something bad, tell us. Why didn't you speak up? You know you should speak up. When people know what's going on, they know what to expect, and they know what might go wrong, they're much clearer about saying, hey, you know that thing we were expecting to see? It's not happening. And so it's gone from speaking up to just notification into discussion about this. It's not going the way we thought it would. So that's been a really big change. On the ward rounds, when we're describing about this is where we're going to get to by tomorrow and how it might go wrong, we're suddenly finding that actually you can cover off the clinical needs, the clinical trajectory for tomorrow, but you're also covering off the safety. And also you're covering off education because you're actually making your thinking explicit. And we're finding staff are a lot more engaged. And the way we're seeing this is people are saying things like, hey, can we have a quick debrief after that recess? Here's an idea why I think we should do this differently. I've noticed the handover is a bit like this from theatre. Could we try that differently? And so we're doing things like, rather than saying we've did a big project on the handover from theatre, we say to people, okay, well, make sure the patient's safe, and then everyone stops listening to a handover. Try it, see what works, what doesn't work, come back to us, and then we'll write it up, and we'll make it more formal. And we're finding staff are much more engaged. They're also engaged with doing process testing for our disaster, evacuations, our Ebola stuff. They're kind of engaged with, it's not saying to them, this is the right way to do it and you should do it. It's saying to them, help us understand how we could do this better, how could we make this easy so that this works. Funnily enough, we're actually getting people saying, can I use a checklist because I'm worried I've missed something? So because checklists are now not something we have to do, they're something that we use because we understand the system's quite fragile. It has quite a different energy to it. And we're slowly, after a couple of years, seeing a different thing. This is now the new normal. It's rugby season. For those of you who follow rugby closely, there's been a change in the All Blacks. And the All Blacks have always been a very good team full of excellent players who play very well together. The difference has been that they are now able to adapt when things aren't going well. They are much more resilient than they used to be. And this is from Richie McCaw, who is, okay. He says, it's probably the biggest learning. It's not just about me, it's about having a good group. I don't pretend to be a know-it-all. You need to have an environment that allows people to give things a go and contribute. The most important thing is to have a collective buy-in to what you're trying to achieve, and you have to do that from the start. I'd like to thank my team. These are the people who are involved in rolling this stuff out and trying to work out how it goes. I'm very happy to discuss with you guys the details of how we do it. Please understand that this by its very nature has to be a very superficial look at what we've done. But I'm very happy to talk to you guys about it. But on this group, this is part of the success is that it's not about the simulation days. It's about people going out there and talking about stuff, rolling it out, discussing it, modelling it. We have in that group 2 specialists. We have actually a 3rd specialist. We have our education team. We have our charge nurse group. and we have our outreach service as well. So there's a whole lot of people who are involved with that help us to model that. I look forward to discussions, arguments and questions, either in 140 characters or via email. Thank you for your time.
Don't go yet. One of the things you mentioned was the benefits of having active followers. Or active followership, how do you go about encouraging that?
I think the thing for us has been about the idea that if, as patients get more and more complex, we understand that we need more and more lenses on stuff. So it's a move from leadership is about saying you do this, you do that, and you're passive recipients, and I'm going to communicate and tell you when I've done it, to actually saying we need to be, that everybody has value in it, but the leader has authority but is not authoritarian. So the active fellowship is really about modelling to people that you can all do stuff and you can respond once we're clear about what we're actually trying to achieve. So we model it, we sort of pull back the curtain of how that looks on a simulation day, and then we talk about it on a daily basis as well. So it's something I think you have to model and show how it works in a simulation setting, just so you can have it in a bit more controlled way. But then it's part of the everyday thing.
Other questions?
I was very interested to see a slide saying about it needs to be easier to do the right thing. I feel that that's my mantra at work, but I found that it's very difficult to necessarily engage the infection control department in adapting the mantra that they give, and I'm just wondering how you achieve that engagement.
I said I was blessed to work at Miramore, and I really mean that. We have, I've actually talked to our infection control team about this model, and they, a lot of the leading stuff in infection control now is saying actually you need to let people find local solutions because their local rationality, their local conditions are changeable, and so therefore they're actually trying to work with people about how does this look for you when you do your job. So I've been lucky enough that we have some very good people in infection control. I'm also blessed by we have an embedded quality and safety person within our unit. And that makes a huge difference because once you spend several years giving them stuff to read and talking to them all the time and harassing them, then they're on board and they start seeing things differently as well. Hi, Catherine. So I think it does take work, but it's about trying to close that gap between, and I haven't talked about here, this concept of work as imagined, work as done. Work as imagined is the work as imagined by people writing protocols who don't do the daily work. Work as done is the work that we do. And what you want to do is to try and get those as close as possible, and that means engaging with the quality of people. And we often say that the gap between those things, between what the protocol says and what we do, is the deficit on our part, but it's actually not. It's they don't understand the work we're doing, and they need to come closer, so trying to engage them about that stuff. I think this is starting to come out, and you'll start seeing it. At the recent APAC Quality Improvement meeting, these themes are starting to come out.
Okay. We have time for one more question. Carl, you talked about resilience. To summarise, what are the key things you can do to generate resilience amongst clinicians?
Again, this is not the personal resilience we're talking about. This is the ability to respond to stuff. And I think it's once you see that the system, the resting state of the system is not that it's safe if everyone does everything right, but the system is something that we actively work at, then that changes things. So I think once you have that understanding, you really start looking at things in a different lens. And I think that shift to thinking, to anticipating problems before they occur, that idea that safety is something that we create every day rather than something that happens sort of naturally unless there's a problem. So I think that's the two messages I'd have would be the resting state of the system is it's unsafe, and it's something that we actively create every day.